Hey guys, welcome back. Am I audible? Am I visible? I hope I'm audible and visible. If so, say me a hi. Okay. Okay. Guys, so we'll have a very quick INICET PYQ recall. So I've taken a sample of 30 questions, which has been spread over from the time it was AIMS, right? Because the older questions also gets repeated in the recent INICET. That's why I've taken from 2018, a little bit from 19, a little bit from 20, and a little bit more in the INICET series as well, right? Whatever has been asked in the recent past, right? So what the aim of this is a final push to see what's the right answer and very crisply to say why it is the right answer. That's all. I'm not going to discuss much about the topic around it unless and it's required to discuss. We'll just go and touch base something related to that. We'll have an INICET marathon for you that is primarily focused on all the important INICET topics which has been asked in the past few years. And I think this and the next session will complete your pathology preparation for the upcoming INICET. Fine. So if you guys are on, so I want you guys to comment on what's the right answer. Let's go quickly brush through the thing and touch base on various aspects of pathology, not just general or hemat, will be systemic, and it will be covering a little bit of other subjects which is lean towards it as well, right? So what's the right answer? Very simple ones. A 2-year-old recurrent bleeding, including from the umbilicus, has a positive urea solubility test. Which of the factors deficient? Right? See, these are pure previous year topics, previous year questions, and I want you guys to write the correct answer. There's no way you're making a mistake here, because if you make a mistake here, you're not ready for the NICT, right? So the answer is a simple one. It's a factor 13 deficiency, right? So factor 13 deficiency has a very classical bleeding from the umbilical cord. A delayed bleeding from the umbilical cord is classical of factor 13 deficiency, right? So we'll just touch base on what does urea solubility test means. Can anyone help me with other name of factor 13? Factor 13 is also called as, you guys, I'm sure you know, it's also called as a clot stabilizing factor, right? So in other words, if the factor 13 is good, the clot stabilizes and becomes firm. Normally, blood clot stays there for a couple of days. After that, the wound healing process will dissolve the clot. Fibrinolytic pathway will happen, right? Now, if factor 13 is present, the clot will be stable for 2 days. If the factor that is not there, the clot will not even be stable for 1 day. That is the function of factor 13, right? So what we do here is we take 5 molar urea solution. Inside the urea solution, you add the patient's plasma and you make a clot formation, right? And the clot is formed. So what we do is we look at the clot at the end of 2 hours and at the end of 24 hours. We look at the clot, we just examine the test tube, that's all. Now I'm going to give you 2 interpretations. I want you to tell which is a normal person and which is a factor 13 deficiency, right? Ready? I want you guys to comment, so please do comment, right? Let's say at 2 hours the clot is present. 24 hours maybe the clot is present. 2 hours the clot is present. 24 hours may the clot is absent or the clot is dissolved, right? This is the person 1, okay? And this is person 2. Tell me, which of these two do you think is factor 13 deficiency? This is the simplest interpretation of clot solubility test. I'm sure you guys know the answer. So tell me which you think will be most likely factor 13 deficiency. It's simple, right? So if the clot is getting dissolved after 24 hours, the clot is not stable, which means factor 13 is deficient. This is a simple principle of factor 13 deficiency, right? Since this clinical scenario is very, very classical, there are few other bleeding disorders also which will have the same scenario, delayed bleeding from umbilical cord. First, I'll think of factor 13 deficiency. I'll also want you to think of Glanzmann thrombocythemia. That also will have a similar history, so don't get fooled only because of factor 13 will have. There's a possibility Glanzmann can also have. With the other findings, you'll be able to answer the question correctly, right? One more thing, tell me which disease will have a delayed separation from umbilical cord stem. Since it's related, delayed separation from umbilical cord stem will be classically seen in leukocyte adhesion deficiency 1 or 2. It's a problem in integrin. Integrin, it is obviously 1. I looks like 1, right? So these are 2 related symptoms, just unrelated disease, but so we discussed about that, right? Next question. I want you guys to answer. These are simple ones, right? This came even in the last year exam. This was a repeat from 2016 AIMS, which came in the last year NEET and INICET as well, right? So what do you think is the right answer? Great, crazy physician. Most common inherited bleeding disorder, is it hemophilia? Hemophilia is not the common inherited bleeding disorder. The most common inherited bleeding disorder is von Willebrand disease. That is most common. Hemophilia is not that common. Hemophilia is something which we might have read. because of its drastic clinical feature of hemarthrosis and muscle hematoma and everything, right? Von Willebrand disease is the most common inherited bleeding disorder. Please don't forget that, right? This also makes sense. We have to read a related question. If there is an isolated prolongation of APTT, okay, if APTT is prolonged, only APT, isolated means only APTT, PT is normal, TT is normal, platelet, everything is normal. Always first thing is rule out von Willebrand disease because that is the most common thing. Then yes, what's the next step? This was also an old INICET repeat. What's the next step if you see a patient with an isolated APTT prolongation? What do you think? The next step is you have to do a test called as mixing studies. Please don't go and say it's hemophilia. You have to do a mixing studies. In mixing studies, we'll be able to say, okay, it's an hemophilia or it is an antibody to factor VIII because symptomatically they'll be same, right? So lab tests also they might be same. So mixing studies is something which has to the next step when it's an isolated APTT prolongation, right? So now let's quickly look at von Willebrand factor and von Willebrand disease. Fine. So von Willebrand disease is an inherited. The most common mode is autosomal dominant inheritance. Okay, there are three major categories of von Willebrand. In that, type A and C are major quantitative defects. Okay, the quantity or the amount of von Willebrand will be less. In type A, it will be reduced. In type C, it will be zero, which means it's very severe. It almost presents as hemophilia, right? And then we have type B. In type B von Willebrand factor, you'll have a qualitative problem. So the amount is normal, okay, but the function is abnormal. That's your type B von Willebrand. In that in type 1, 2, and 3, not A and C, right? So 1, 2, or room number 1 and 2, or normal 1 and 2, and this in this type 2, fine. All these 2, okay, not A, B, C, 1, 2, 3, fine. Apologies for that, okay, fine. So in type 2, there's a problem in connecting with von Willebrand and your platelet glycoproteins. Could be a problem. Could be a problem in the von Willebrand or could be a problem in the platelet glycoprotein. It's functionally defective, right? All three of them, more or less, presentation will be the same. Since your type 1 is the most common subtype and that inheritance is autosomal dominant, that's the reason it's most common autosomal dominant inheritance, right? One more thing I want you to remember, just a random question, not related to von Willebrand disease. In any autosomal dominant disorder, when do you think the patient will present? Early in life, later in life? What do you think? In any autosomal dominant disorder, when do you think the patients will present? Early, later? Most of the dominant disorder present later in life, at least little bit more than adolescence, right? It's not early. Just remember, dominant means there will be a one allele mutation. The other allele will be completely normal, right? So obviously, that normal allele will take care of little bit of time. They'll always present later, adolescence, adulthood, minimum. They will not present during infancy or childhood. Recessive will always present during infancy, fine. So now let's assume it's a man or a woman. Most common is type 1, which is slight deficiency of von Willebrand factor. So there'll be bleeding after trauma. The most common presentation of von Willebrand diseases, they will present with puberty menorrhagia. I want you to remember this. It's not just for an exam. The same thing came in NEET PG as well, right? But most common in real life also, they'll present with puberty menorrhagia. Patients comes with puberty menorrhagia. It's a trauma, obviously. You rule out all the hormonal causes first. By default, that's a most common thing, right? Which sir will talk about that. Once that is done, then at least if it's an inherited bleeding disorder, think of von Willebrand disease. This presents with puberty menorrhagia. You have to remember it, right? Just a relation to medicine. Can anyone tell me what's the treatment of von Willebrand factor? That gives us one more MCQ as well. Treatment is desmopressin, intranasal desmopressin, the vasopressin analog. So how it helps is, it will immediately release all the stored von Willebrand factor from the endothelium. So in endothelium, we have stored von Willebrand factor, right? All those things will be released and be removed with the help of your desmopressin, right? Perfect, done. Next question. This was a last year's exam question, right? Which of the following is an incorrect association of genes? Not the right one. Okay, type 1 is reduced von Willebrand factor. Type 2 has multiple types like MN, 2N, 2N, M, 2S, multiple subtypes. All of them are problems in the functioning of one valvular bladder. Type C has 0 one valvular bladder, so it almost always presents like hemophilia. Fine. Okay, STK, see the question is which of the following is an incorrect association, right? STK11 is definitely Peutz-Jeghers. But yes, Peutz-Jeghers syndrome also has an increased risk of breast cancer, right? It's not, Peutz-Jeghers is a syndrome, not only colonic. It has increased risk of breast cancer. Please do remember, Peutz-Jeghers syndrome also has a very, very high increased risk of pancreatic cancer. Please don't read only the important facts. This is how it is. There's close to 50 times increased risk of pancreatic cancer with patients with Peutz-Jeghers syndrome. So all those are syndromes, right? When I take neurofibromatosis, you would say schwannoma is a component, meningioma is a component, not just neurofibroma, right? So these are components. BRCA syndrome, right? Prostate, breast, ovary, multiple things will be on, right? So this is a correct match. P10 thyroid carcinoma is a correct match. BRCA2 prostate cancer is a correct match, right? But TPIF3 and mucosal neuroma is a wrong match. Option A is the right answer. Like I've said, option 3 is the right answer, right? Ram and Kav said option 3 is the right answer, which is the wrong match. So just since we are in the mucosal neuroma, can anyone tell me in which of the cancer syndromes you will have mucosal neuroma? That cancer syndrome is also important for us to remember. That's also an important PYQ as well. Which cancer syndrome will have mucosal neuroma? It is men. Okay, type 3 ka. Men 2A or B? Men 2B, right? So we have men 1, 2A and 2B, right? So perfect. So men 1, you have a mutation in a gene called as menin gene. See, men 2A and 2B, both of them are mutation in the ret proto-oncogene. Do remember, there's a simple trick that almost every cancer syndromes are tumor suppressor genes. Almost everything is a tumor suppressor gene. Ret is a proto-oncogene, remember that. And there's one more thing, a syndrome called as Beckwith-Wiedemann syndrome, right? In Beckwith-Wiedemann syndrome, we have WT2 gene. This also is a proto-oncogene. These are the only 2 proto-oncogene related cancer which an undergraduate need to know. Rest everything is a tumor suppressor gene, right? Now tell me, what are the features which are common for men 2A and men 2B? There are 2 things which are common for men 2A as well as men 2B. 2 tumors. One is there in the thyroid. We have possibilities of increased risk of medullary carcinoma of thyroid by default, and also we'll have an increased risk of pheochromocytoma, right? So these are 2 common things which we've seen in case of men 2A as well as men 2B. Men 2B will have, in addition to that, mucosal neuromas and marfanoid habitus. The patient will be very, very tall, right? Men 2A will have, in addition to that, parathyroid hyperplasias. Fine, perfect, great. Okay, next question. This was a recent question. What's the answer? Serous ovarian tumor, mucinous ovarian tumor, endometrioid tumor, and the granulosa cell tumor. Actually, this options should have been a little bit more refined. I'll change this to serous ovarian carcinoma and a mucinous cyst adenoma. And let's say this is 1250 value. What will be the answer? Even otherwise, I can tell it is serous carcinoma. I'll give you clues for that, right? See, there are few things which you have to remember. This came in the recent exam, and there's a confusion that it's a mucinous adenoma or a serous carcinoma. You should never have a confusion. There are simple keywords here. Ascites, possible in malignant or malignant? Obviously, as it is possible in malignancy, right? Omental caking indicates metastasis. Obviously, possible in malignancy, right? Solid component is there. Whenever there's more amount of solid area in an ovarian tumor, I always think of a malignancy, not an adenoma. Always we think of adenocarcinoma. And a CA value of more than 1000 any day. All these are pointers for a cancer, not a benign lesion. If it's a cancer, The most likely possibility form is in serous adenocarcinoma because that undergoes very early metastasis, right? Now I'm going to ask you a simple question. I want you guys to answer. Granulosa cell tumor, is it a benign tumor or a malignant tumor? What do you think? Granulosa is benign or malignant? Granulosa is a malignant tumor, right? It's a malignant tumor. It's not a benign tumor, right? Now my question is, if granulosa is also malignant tumor, that also can cause ascites, that also can cause omental caking. So why it's not the answer? Why did you prefer serous ovarian tumor? Because in the option, there's not even carcinoma, there's tumor. Why did you prefer 1 over 4? Because that is also malignancy. Anyone? What's the right answer? CA125. Perfect, right? So this CA125 is not just a tumor marker, it's an epithelial ovarian tumor marker. Please be very, very specific when you read. It's not a tumor marker for the ovary. It's a tumor marker for the epithelial tumors of the ovary. Your granulosa cell tumor is a sex-cord stromal tumor. It will not be elevated in dysgerminoma. Dysgerminoma is also malignant. It's a germ cell tumor, right? So that's how it helps here. The tumor markers do come handy for us to cement the diagnosis, right? Can anyone tell me where do you see this tumor marker? I'm going to write random things which comes to my mind, right? CA15-5. Where do you see them? CA19-9. Where do you see them? CA15-5, you see them? 19-9, you see them? Pancreatic. 15-5, you left. 15-5, you see them in breast cancer, right? 99, you see them in pancreatic cancer, right? Perfect. Where do you see? I'll give you a simple one. Beta HCG. Where do you see alpha fetoprotein? Beta HCG is primarily seen in case of anything related to placenta. If it's malignancy, I would go with choriocarcinoma, right? If it's kind of not a malignant condition, I'll go with molar pregnancy. Like high for molar pregnancy also, it will be elevated, right? AFP, two conditions. One is HCC, hepatocellular carcinoma, perfect. The other, do not forget non-seminomatous germ cell tumor, right? Like especially your yolk sac tumor, alpha fetoprotein will be very highly elevated, right? Good guys, fine. Okay, next. What's your answer? It's simple one. Okay, Kritika has gone with A. Okay. Fine. So neurosecretory bodies are classical tumor markers of neuroendocrine tumors, right? So every neuroendocrine tumor will have neurosecretory bodies. Neurosecretory bodies are nothing but the secretory granules. This is actually an electron microscopic finding seen in, that's also a very old PYQ of Germ exam, seen in case of an neuroendocrine tumors, right? Any neuroendocrine tumors will have this. So how do I know it's a neuroendocrine tumor? When some cell secretes on a neural impulse, I call it neuroendocrine cells. The best example is, can I call gastrinoma or gastrin secreting cells as neuroendocrine? It is. It secretes on nerve impulse, right? Medullary carcinoma thyroid comes from a parafollicular C cell which secretes calcitonin based on the neural impulse. It's a neuroendocrine cell. Pituitary adenoma, obviously, completely neural impulse. Paraganglioma, same. It's a sympathetic ganglia, right? Neural impulse. Pheochromocytoma, neuroendocrine. Neuroblastoma, neuroendocrine. Adrenal cortical tumor does not secrete with neural impulse, right? Adrenal medullary tumor, yes, it's a neuroendocrine. Because in adrenal medulla, it's a sympathetic ganglia. So adrenal medullary tumor is nothing but your pheochromocytoma, right? Pheochromocytoma is a neuroendocrine tumor, not your adrenal cortical tumor. Adrenal cortical tumor is not a neuroendocrine tumor. That is the right answer here, right? Rest three are all neuroendocrine. The good thing about categorizing subject and learning topics properly. Neuroendocrine tumors, almost everything have few commonalities. One, there's a classical finding in a high power microscopy, which is salt and pepper chromatin. You must have heard this, obviously, right? Second, almost everything here are positive for synaptophysin, chromogranin. But if everything is positive for synaptophysin, chromogranin, they are not the specific markers, right? That's why for your medullary carcinoma, I have calcitonin. But yes, it is positive for synaptochromogranin also, right? CD57. And for all these tumors, you might have secretion related symptoms. The symptoms will generally be related to the secretion of the component, pheochromocytoma. It secretes catecholamines. Symptoms might be a headache, palpitation, sweating, high BP due to that, right? Okay. Fourth, all of them electron microscopic finding will be very, very electron dense neurosecretory granules. These are nothing but the granules which are seen inside the cell, which is composed of all the secreting components, like calcitonin in case of a medullary carcinoma thyroid, catecholamine in case of an adrenal medullary tumor. Fine. Okay, these are common for every neuroendocrine tumor across the body. Now, I'm going to ask you a simple question. We'll complete with that. We'll go to the next question. Can I say carcinoid to be a neuroendocrine tumor? Yes, no, maybe. Carcinoid is a neuroendocrine tumor. Yes, carcinoid is a neuroendocrine tumor. So carcinoid will have salt and pepper chromatin. Carcinoid will be positive for synaptophysin. Carcinoid will have secretory symptoms. Carcinoid syndrome, you know that. And carcinoid, if required, electron microscopy will have it, right? They do secrete, right? That's it, fine. Everything will fall into a place. Okay, next one. It's a simple question. Maybe not an amazing image, but yeah. Not a superb diagnostic point as well. What do you think is the answer? See, this is primarily an orthopedic question, right? So sometimes when you go to an INICET exam, you will have an image which is unrelated. You might have a medicine question with a very strong biochemical background. You might have a pediatric question with a very strong genetic background, which you are going to write from pathology, right? Whenever you have questions which are not, I'm not able to separate to one particular subject. I want you to go with your strongest suit. Now, this image is not a stronger suit at all. We don't even know what is there. It said it's a synovial biopsy. If they are not told synovial, we won't even know it's synovial, right? So that's not my strongest suit. So I'm going to go with age. 72-year-old, pain in the hip. Now tell me, do you think rheumatoid arthritis will present with pain in the hip? Yes, no, maybe. Since your strongest suit here is clinical history, right? Rheumatoid arthritis will not present with pain in the hip, right? It will not. So I'm going to rule it out. Rheumatoid arthritis presents with the tiny joints. You'll have early morning sickness, right? Gone. Lyme's arthritis, possible, but knee is more possible. But again, Lyme's arthritis will not present primarily with the hip problem. It will be a fever, malabsorption, you'll have neurological symptom, many things will be there. It's not just an arthritis, right? Okay. TB hip again will not present with just pain in the hip. I'm having a reduced joint space, pain in the hip, and if it's a TB, I will see granuloma. I am not seeing granuloma here also, right? The only thing I'm seeing here is little bit of lymphocytic response. That's all. And little bit of hypertrophied synovium. That's all. Fine. Great, Rocky. All the best. Right. So the only possibility here for me is osteoarthritis. When a question comes which is totally unrelated, like a bouncer like this, don't get perplexed. Don't leave the question. Go with your strongest suit. You can easily eliminate and you can write the right answer. Right. This is what you guys did during internship. Internship, you had few history, few investigation findings, you ruled out and you went it. And most of the time it was right? So if you can save patience, you can definitely solve MCQs, right? Next question. Yes, Rukmani. You should have Jane cells and granuloma for TB hip. That is not there in the microscopy. Plus on top of that, any TB should have the fever, weight loss. That's characteristic template, right? You're not going to miss this. It's a very, very easy one, right? Simple one. It's Ewing sarcoma, right? MYC2 was a very, very old marker. CD99 was the other name for MYC2. Okay. Can anyone tell me the new markers for Ewing sarcoma? Ewing sarcoma has lots and lots of new markers. Can anyone tell me new markers for Ewing sarcoma? Ewing sarcoma is a diaphyseal lesion. Ewing sarcoma will definitely have your small round blue cells. Everyone knows that. Ewing sarcoma in your radiology will have your onion peel appearance. Everyone knows that. Okay, Ram is more or less right. We'll take Ram's thing. One is FLI1. I'm not denying that. Fly1 is a very good marker. Anything better than Fly1. Fly1 also has become a little bit older. I'll tell you why it has become older and why I'm relying on the newest markers, right? The newest marker is NKX 2.2. Expect this in an INICET exam. This has been the kid in the block, new kid in the block. Every pathologist uses NKX 2.2 as a marker to diagnose Ewing sarcoma because of the genetics. Actually, Ewing sarcoma has a very strong genetic role, right? Can anyone tell me the translocation seen in Ewing sarcoma? This was also asked in INICET multiple times, right? The translocation seen in Ewing sarcoma. You have translocation between 11 and 22. You have translocation between 21 and 22. The concern is the 11-22, one of the thing is FLI. So FLI1 will pick up only the 11-22 translocation. FLI1 will miss the 21-22 translocation. But this NKX 2.2 will pick up both the translocations, right? 22 is a common one, Ewing sarcoma related region of genes in the chromosome, right? So there are two, this is definitely the most common. So this is very good compared to your CD99, but NKX 2.2 is undoubtedly better than that, right? So now, I'm sure you know this PYQ. There's a question which is asked, what will be the genetic test you will do to diagnose Ewing sarcoma? Karyotyping of fish. Simple one, right? So, undoubtedly fish. Fish is much better than karyotyping for case of an Ewing sarcoma. Not just Ewing sarcoma, I'll tell you the rule. You read the rule, you solve any question, not just PYQ. If you have a known translocation meaning is very simple. That if I'm suspecting CML, do you know the translocation? Yes, we do know, right? 922. Mantle cell lymphoma, I know. Burkitt's lymphoma, I know. If it's a known translocation, I always prefer fish. I don't prefer karyotyping because fish is specific. Fish needs probes to diagnose. On the other hand, when it's an unknown translocation, best example is, what is the most common cause of first trimester abortion? One of the common cause? Chromosomal anomalies, right? That's one of the common cause of first trimester abortion. Can you tell, looking at the abortus, okay, it's trisomy 15 abortion, trisomy 16 abortion, or trisomy 17 abortion? I can't, right? So if there is an unknown translocation, I don't know what I'm looking at. So I look at all the 46 chromosomes. The best example is abortus. In an abortus, when I'm looking for translocation, I use karyotyping. I don't look for fish because I don't know what I'm looking for. If I know anything, I go for this because karyotyping is a very sensitive test. It's not a specific test, right? Perfect. Next guy. Simple guy. Answer. Below is an image of an ovarian tumor, the most common diagnosis. This is a classical finding. The common diagnosis. Perfect, right? Why did you guys take much time? That's like a blood vessel in the center, and you have two layers of tumor cells. Schiller-Duval body is also called as a glomeruloid body because it looks like a glomerulus. A vessel in the center surrounded by two layers. Glomerulus is a vessel in the center surrounded by parietal layer, visceral layer of epithelium. Similar to that, we have this. That's why we call it glomeruloid body, and as a classical finding for yolk sac tumor. If image is not given, the best clue for yolk sac is age. Remember, any tumor in a kid less than 5 years, adnexal mass has to be yolk sac unless proven otherwise. That's the most important thing. See, because a tumor always requires lots of years to grow. This tumor started in the intrauterine life, originating from yolk sac, right? So that's the most important clue here, fine? Okay. Dysgerminoma. Since we are in this place, we look at the markers of dysgerminoma, which has been asked before. Can anyone tell me what are the markers comes to your mind? CD117 is good. There's one useless marker. I'm sure everyone knows that, which is not useful, but only the exam authority loves it. PLAP. PLAP has a sensitivity specificity of close to 50-60%. No one uses PLAP in recent days. CD117 is a very good marker. CKIT is a very good marker. I'll come to LDH Rukmani. 1 second. I'll come to it very soon. Fine. Better than this, you have perfectors. We have OCT3/4, nanog. These are also becoming old. We have a better marker than OCT3/4 nano, which is SAL4. Since INICET likes the latest ones, the latest marker for germ cell tumors of the testis and ovary is SAL4. We are more dependent on SAL4 than OCT3/4 nano. I'm not saying this is bad. They are good, but SAL4 is better, right? Now coming to LDH. LDH and PLAP is not useful for me to diagnose. PLAP is, like I said, very non-specific marker. I'm not going to talk about that. But LDH plays a role because LDH tells me the tumor size. That's the only role of LDH. LDH is a cells marker, right? Even in case of a myocardial infarction, we use LDH. So when the tumor size is more, the LDH will be more. When the tumor size is less, automatically LDH becomes less, right? So that's the thing. But yes, LDH can be used for tumor for many conditions because it's related to the cells number and cell size, right? Next question. Tell me the answer. Just give me a second. What do you think is the answer? Differential expression of genetic material is seen in which of the following condition? This was a very old one-liner which is asked in one of the recent exams in the INICET. It's the other name or the definition of genomic imprinting. That's all, right? The other name or the definition of genomic imprinting, that's the place where you have maternal imprinting, paternal imprinting, right? In Angelman's, the ubiquitin 3A will be imprinted from the dad sides, right? In Prader-Willi, the SNP gene will be imprinted from the mom's sides, right? Based on the genetic material, based on gender. Actually, it should be based on gender. Fine. Based on gender, the change is imprinting. Do remember that always, right? Since someone answered mosaic, I'll talk about a little bit of mosaic as well, right? Mosaic is a post-zygotic change. Okay, it's a post-zygotic change. So let's say a person in a 4-cell stage, one cell alone got a random mutation. So whatever cell develops from this will be mutated. Roughly, I'm saying 1/4 will be mutated. Rest everything will be normal. That's mosaic. Rest being normal and mutated. So mosaic ka matlab is both the patient will have two genotypes. One will be normal, one will be abnormal, right? That is the classical explanation for mosaic. Fine. Okay. Do remember that mosaic is not differential expression based on gender. Based on gender is nothing but your imprinting. Okay. Okay. Next question. What's your answer? A simple one. What comes to mind? It's an easy one, right? We'll quickly have a look at other stains also here. Fat stain has to be done with frozen section, right? It's not difficult at all. You have to use a frozen section because fat gets washed away during processing. When you process tissue, because of the alcohol, fat gets washed away. Since fat gets washed away, you have to do a frozen section for fat. Fine. Okay. Now, since we are here, can anyone tell me the fixative for a normal HNE? I'm going to write what all test we have, and you're going to tell me what all fixative is used there. A fixative for direct immunofluorescence or the biopsies what we use in kidney and the skin, the green and the black one. The fixative for electron microscopy. The fixative for Leishman stain. Leishman stain is the stain what we use for your peripheral smear, right? And the fixative for your new methylene blue stain. The new methylene blue is a stain what we use for your reticulocyte count, right? HNE, the fixative is formalin. 10% neutral buffered formalin or formalin is good enough. DIF cannot be done on formalin fixed tissue. DIF has to be done either frozen or saline or a transport medium called as Mitchell's medium, right? Mostly it is done in saline or Mitchell's medium. Because why we need a transport medium of Mitchell's medium is not every patient, every hospital will have immunofluorescence. So I take it biopsy here. Okay, the hospital is like 5 hours away. I put in the transport medium, send it across, right? Electron microscopy, there are multiple ones. Glutaraldehyde is something which is easy, right? And obviously you have your osmium tetroxide as well. See, fixatives and all these techniques, your INICET prefers them a bit better, right? Osmium tetroxide, right? Leishman, what we use in peripheral smear. Here, it's very specifically acetone-free methanol. Acetone should not be there. If acetone is there, the RBCs will burst. So it has to be acetone-free methanol, right? And because of acetone, you'll have RBC lysis. And your methylene blue, there is no fixative. That's why we call it supravital stain. It has to be live cells. I cannot do a reticulocyte count on a fixed cells, right? Fine. Last but one question, pap smear ka fixative. Pap smear, you have your 100% or absolute alcohol or your 95% alcohol, whatever is the closest, go with that, right? It's an absolute alcohol. 95% may be there, 100% may be there. Or if it's not there, I want you to look for isopropyl alcohol. Isopropyl alcohol is commercially available fixative because 100% ethanol spirit is very difficult to get. Fine. Ethyl alcohol, ethanol, alcohol, anything. Fine. Perfect. Okay. The next question. Old one, we have forgotten COVID, but if something comes behind, we have to remember. This question is not only for COVID. This is a question for any cause of ARDS. Acute respiratory distress syndrome, any cause, the answer is the same. It is. Okay, the question is, what's the most common cause of lung injury in case of COVID or ARDS, right? What causes the lung injury? What's the starting point? It has to be an endothelium damage, no? This is the outcome. Diffuse alveolar damage is the outcome of ARDS, outcome of COVID. COVID as well as ARDS, it starts with endothelial injury. Please do remember, the damage is never to the lung parenchyma. The damage is always to the endothelium, right? You have to remember this because we have lived through COVID, right? What's one of the important tests you must have done during COVID? During COVID, if you had your family members having COVID, we do ferritin, we did CRP, we also did D-dimer. Because if the endothelium is damaged, you'll have clot. If the clot lyses, D-dimer gets elevated, right? Endothelial injury is very, very important, right? RT-PCR is fine, that's to identify the organism, right? But what is required for me is the D-dimer, which tells me is an indirect evidence of endothelial damage. If endothelium is getting damaged, you by default will have a clot. Post-clot there will be lysis, you'll have D-dimer, right? Endothelial injury is the starting point of ARDS, starting point of COVID, the cause of lung injury, and the outcome is diffuse alveolar damage. Fine? Okay. Next question. Which of the following is not a small round blue cell tumor? What do you think is the right answer? Small round blue cell tumor has a characteristic, right? All the tumors ending in blastomas are small round blue cell tumor, right? Every tumor which has the name embryonal is a small round blue cell tumor. Every tumor which is undifferentiated, like Ewing sarcoma, right, is a small round blue cell tumor. Fine. All these are small round blue cell tumor. But obviously exceptions are there. Exceptions are MCQs, right? For blastoma, there are two exceptions. Glioblastoma is not a small round blue cell tumor. And also hemangioblastoma is not a small round blue cell tumor, right? These two are not small round blue cell tumor. Synergism, Ewing sarcoma is a small round blue cell tumor because that is an undifferentiated tumor. Embryonal rhabdomyosarcoma, small round blue cell, right? Small round blue cell, not a small round blue cell tumor. Any small round blue cell tumor has a template. Like I said, there's a template for your neuroendocrine tumor. There's a template for your small round blue cell tumor. If you remember templates, medicine is very, very easy. There are rules, that's all. And every disease, most of the disease plays by the rules, right? I said it's an undifferentiated tumor. When do you think you'll have undifferentiated cells more? When we are children or when we are adults? Generally when we are children, right? Generally when you're children, we'll have your undifferentiated cells more, right? So all these small round blue cell tumors, small round blue cell tumors, most of them are seen in first or second decade of life. Think about them. Neuroblastoma, infancy, retinoblastoma, children, right? Everything. Most of them will be seen in first and second year. E-wings, seen in children, right? Most of them are seen in children, right? Second, the microscopy. Microscopy will have small round blue cell, right? In addition to that, most of them also do have rosettes. Rosettes is not must, but they do have. Retinoblastoma, flexner of intestinal rosettes. Homerite rosettes in neuroblastoma. Ependymoma is a small round blue cell tumor, undifferentiated, first or second decade of life, right? So it's important. We have flexner intestinal rosettes. Where do you see? I'm just going to write the rosettes. You tell me at least one condition where you see them. We have Homerite rosettes, and we have something called an true ependymal rosettes, and we have something called an perivascular pseudo rosette. Fine. This, as the name says, it's seen in ependymoma. Perivascular is not specific. I can see them in ependymoma, I can see them in Ewing sarcoma, neuroblastoma, everything we can see, right? Homerite is seen in neuronal tumors, neuroblastoma, and medulloblastoma. Fine. This is a pseudo rosette. Remember them. The other pseudo rosette is your perivascular pseudo rosette. It's there in the name, right? Flexner intestinal is seen in retinoblastoma. Fine. Okay. Some things which might come in an exam. Okay, next question. Few questions related to iron metabolism. What do you think is the right answer? Hepcidin inhibits which of the following protein? Hepcidin is considered to be the master regulator of iron metabolism. You guys know that. And hepcidin inhibits your ferroportin. Hepcidin inhibits your ferroportin. It's a very simple thing, right? It does not inhibit hepcidin, right, Ram? It inhibits ferroportin because ferroportin is the one which pushes the iron outside, right? Now I'm going to just ask you a simple question. If hepcidin does not work, ferroportin is not inhibited, what disease you will have? That's the basic of one disease. A disease when hepcidin fails to work, it's not present, absent, or it's not functioning, right? What will happen to ferroportin? No one to block ferroportin, so there'll be excess iron outside. Perfect, Ram. You will end up in having hemochromatosis, right? There are multiple types of hemochromatosis. The HFE gene, JB gene, everything, and there are like 6-7 types, right? But ultimate thing is my hepcidin will not work. No one to block ferroportin. Iron keeps on coming outside. Will end up in having hemochromatosis. Fine, great. Okay. This is something which keeps on repeating. I'm sure most of you guys must have memorized the iron profile. I'll tell you a very easy way to remember iron profile. Iron profile has 4 components. Most of the time, iron profile has just 4 components, right? You have serum iron, right? Most of the time, iron profile is you have serum iron, you have transferrin saturation, you have serum ferritin, and you have TIBC. Always write in the same order. It's easy to remember because iron and saturation are always directly proportional, which means iron increases, saturation increases, iron decreases, saturation decreases. These two are always inversely proportional, right? A few more questions. We'll be done. We'll be done soon. Maybe half an hour. Okay. So in iron deficiency anemia, reduced, saturation reduced, ferritin is the first one to reduce, TABC elevated. Easy way to remember. Direct inverse. In anemia of chronic disease, find AOCD is anemia of chronic disease. Put a star mark here. I'm going to start doing the problem math with ferritin because ferritin is an acute phase reactant, right? Chronic inflammation, it will be elevated. Because of that, this will be reduced, this will be reduced, this will be reduced. Fine, if ferritin is reduced, so if ferritin is elevated, TABC will be reduced, right? So that's the combination. It's a very simple to recollect also. Don't memorize. It's a simple thing. Directly proportional, inversely proportional, right? Ferritin is being reduced, so obviously it's wrong, this is wrong. So here, again I have an issue. TABC will be elevated. Like I said, option A is, or option 1 is the right answer, right? Perfect. Next one. AIMS or INICET keeps on changing few times. Like they do ask match the following sometimes. They don't ask match the following sometimes. So don't go with the pattern. They always wants to feel superior. They keep on changing the pattern. If it comes, it might help you. That's it. Burkitt's lymphoma. There are few useless tricks which my seniors told me. I'm going to tell it to you, right? We always call them Burke 8 lymphoma. So it's translocation 814. And we always spell them MANT L, not TLE, LLE, right? So mantle lymphoma, its translocation between 11 14. 14 is always common for non-Hodgkin's lymphoma, if you noticed, right? Follicular lymphoma is translocation 14 18. Okay, so marginal, no, it's multi heterogeneous. I can have multiple translocations there, right? Burkitt's is, where is your 8 14? One is C. Mantle is your 11 14. Sorry, it's not 11 18. Mantle is your 11 14. Follicular is your 14 18. And your marginal zone lymphoma is your 11 18. Right? So answer would be, I'm going with you guys, 1C, 2D, 3A, and 4B. Right? These match the following needs concentration. Like I missed, I saw 11 and I jumped to 11 14. Right? That might lose your mark. Match the followings are generally easy because if you get 3 right, the other one will be easily sorted. Sometimes based on the options, even 2 right will be enough. But be very careful in match the following. Read it, spend some time, you will definitely get the right answer. Okay, simple question. What's the right answer? It's a classical finding, right? What's the finding? It's your classical knuckle hyperpigmentation, right? Classical knuckle hyperpigmentation. It's diagnostic of your megaloblastic anemia, right? Megaloblastic anemia can be due to two problems. Can be due to B12 and can be due to folate. I'm not going into the ways by which we do a medical lab test to differentiate B12 folate. I don't want the different tests. I want simple history and examination findings to differentiate B12 and folate, right? What are simple history and examination findings to differentiate? If it's a history of vegan, I'll think of B12, right? If it's a history with not vegetarian, vegan, history with less fruits and greens, this is very, very important. Or a history with alcohol, because alcohol will inhibit folate absorption. Fruits are the richest source of folate because folate is a heat labile vitamin. Folate is very much available in milk. Folate is very much available in meat also. I cannot eat a raw meat. I can eat a banana without cooking. I need to cook meat and I need to boil milk to eat and drink. So obviously the amount of folate reduces, right? So please do remember, diet reduced in fruits and greens and alcohol ingestion will inhibit folate absorption. One of the important cause of folate deficiency, right? And like Ram said, history also will help me find your neuronal manifestations. If you have a neuronal manifestation present, I'll think of a B12 deficiency. Only your anemia and other things, I'll think of a folate deficiency. Here, neuronal manifestation mind absent because B12 is involved in myelin synthesis, right? Obviously, there are lots and lots of tests available in biochemistry. You will read them, but these are something which is very, very basic to remember, right? Subacute combined degenerative spinal cord is important. Okay, answer. This actually was a very good question, not a recent one. Some of you must have seen this question, some of you might have not, but if this type of question repeats, you have to remember it and write it. You must have seen protein electrophoresis for multiple myeloma, right? It's similar to that. Looking at the serum protein electrophoresis, what will be the right answer? See, first of all, not every protein electrophoresis is multiple myeloma. Don't expect exams to be coming from your notes directly. That is a very false ideology. Your doctors, right? Disease don't read textbooks. That's not a multiple myeloma at all. We'll zoom it out. For multiple myeloma, I need a M spike. M spike is your gamma globulin or your immunoglobulin. Here, gamma globulin is the least, right? It's the least here, right? The yellow one is the normal one, right? And the pink one is the patient's one or the question, whatever it is. M spike would have been like this. That's M spike. If albumin and your gamma globulin is equal, I can call it an M spike. So it is not there, right? Now, what exactly the patient is showing? Let's write it. In this is for albumin, fine. In this patient, albumin levels are less, fine. And your alpha 2 macroglobin levels are more. Gamma is slightly less, beta slightly less. I'm okay with that. It's very marginal reduction, right? But these two are marked and significant. Now let's go to the options. If a question is new, wait for some time. Albumin being low, which condition comes to your mind first? This also albumin will be low. Can I say in liver cirrhosis also albumin will be low? Yes, no, it will be. These two I'm going to rule out. It is not related with hypoalbuminemia, right? Nephrotic may albumin will be low. Cirrhosis also will have less albumin, right? So first two is ruled out by default. Fine. Now I have to differentiate between cirrhosis and nephrotic syndrome. In cirrhosis, you are going to answer me. Can I say every protein production will be reduced or only albumin because liver is failing? Every protein production will be reduced, not just albumin, which means alpha 2 macroglobulin also should be reduced, right? So here there'll be reduction in alpha 2 macro also. Why that alone should be exempted, right? So it is not liver cirrhosis. It's not fitting into liver cirrhosis. Now let's see why nephrotic syndrome. Because the alpha 2 macroglobin, no, it's a big protein, difficult to escape outside, and the liver will compensate and extra produce because liver assumes that albumin itself is going, let's function more and produce everything more, right? So here alpha 2 macroglobin will not be excreted in urine, and to compensate, in patients with nephrotic syndrome, liver overproduces or overcompensates. That's the reason we have elevated alpha 2 macroglobin and this, fine. See, beta gamma band will be seen, Ram. It'll be less. That's all. See, it's not like it'll be disappearing. Everything will be less. But also keep in mind, if a cirrhotic patient has any infection, gamma globulin will shoot up because it's immunoglobulin. That's it at the end of the day. Fine. Okay. And sometimes if there's an infection, liver is the one which metabolizes IgA. IgA, your nephropathy, one of the causes liver failure. Sometimes gamma globulin can be a little bit high because liver will not be able to metabolize the immunoglobulin produced. Fine. Okay. Next question. Simple one. Very easy one. Cell arrest due to DNA damage is done by the guardian angel of the genome, which is P53, right? P53 stops an arrest cell cycle whenever there's a problem. Automatically, that becomes a guardian angel. It'll try to recover the cell from errors. If not able to recover, it'll kill the cell by apoptosis, right? Perfect. Next guy. Yes, Ram. What process should be done to blood before transfusion to reduce the chance of febrile non-hemolytic transfusion reaction? Febrile non-hemolytic transfusion reaction, what's the reason? It's non-hemolytic, generally due to HLA problem. It's ideally due to very minor HLA mismatch is the reason what happens, right? In your blood transfusion, I have RBC, WBC platelets. The only one which carries maximum HLA is WBC. So this is an HLA mismatch issue. So the only way to prevent that is to remove HLA, and to remove HLA, the best way is to remove WBCs. So once you have a leukocyte reduction, using a filter, automatically the WBC is gone, the HLA is gone. If HLA is gone, febrile non-hemolytic transfusion reactions incidence will become less. It will not become zero, it will become less, significantly it will reduce. Fine, perfect. Ram, allergy is always followed by a sensitization phase. I get exposed today with an allergen, I won't have a reaction today. The second time I get exposed, I'll have a reaction for second time. Anaphylaxis, you'll have the reaction in the first time itself. That's the difference between allergy and anaphylaxis. And anaphylaxis is severe in the severity. Allergy might not be life-threatening. Okay, this is again, you might have expected your CD 1656, it's not there. So if your CD 56 and 16 and 56 not there, CD 94 is also a marker for NK cell. Please do remember that. Again, these are rare questions, but if the rare question gets repeated, I want you guys to remember it. Okay, fine, never forget it. Okay, next. Okay, Rukmani, where is irradiation done? Say, we will irradiate the blood product, especially, see, irradiation also serves most of the same purpose, to prevent transfusion associated GVHT or again HLA related reactions, right? But irradiation is a bit difficult. You need a blood bag which has to be taken to a place which can have irradiation without affecting others. But put a filter, it's a bit easier. Irradiation is same purpose, but bit more stringent. Okay, simple one. That's your classical strawberry gallbladder, which is seen in cholesterolosis, right? The classical strawberry gallbladder, which is seen in one form of chronic cholecystitis, which is cholesterolosis. Fine. Gallstones and gallbladder calculi, there are very simple questions which can be asked. We have two types of gallbladder calculi. One is cholesterol stones. You know the place where they see them, fat 40 fertile female, and the foreigners, you see them. And the other one is pigmented calculi, right? Pigmented calculi, there are two conditions where you see pigmented calculi. One is a hemolytic anemia. Fine. Okay. One is your hemolytic anemia. That's where you see pigmented calculi. Second, you see them in case of an infections. If there's a gallbladder infection there, like an ascaris or anything, any of the infection, you'll be seeing it, right? Now, one more question related to it. Can anyone tell me, where do you see, in which hemolytic anemia you see gallstones as a presenting finding? That's the first one. Second, you will see them in an acute hemolytic anemia or a chronic or a recurrent hemolytic anemia. Where do you see? Perfect. You will see very commonly as to with hereditary spherocytosis, right? That's one of the classical presenting feature for hereditary hemocytosis. Fine. Okay. It's almost always in only in chronic condition. In acute condition, you won't see them. Fine. Okay. Ram, most common association with FFP or whole blood. See, when you go with incidence wise questions, the answer changes based on the paper, based on the book you follow. Fine. FFP was initially considered one of the important thing about with respect to Trali, but over the period of time, the way we produce FFP, everything has changed. So whole blood, again, I don't use whole blood anymore. It's always product based, it's PRPC based, right? We have changed a lot. So these questions which are very old might not make sense in the current scenario. So I would say go a little bit away from this more factual questions, which doesn't make sense now, right? Okay. Answer: neuroblastoma, NMYC, Burkitt's lymphoma, CMYC, retinoblastoma, obviously the easiest one, RBG, right? Okay. And the last one is your pleomorphic adenoma, which is plaque 1. So like I said, you just need concentration here. You need not know everything here. Everyone here knows retinoblastoma and RPG, right? So 3 has to be B. So this is wrong. This is wrong. 3 is to be B. The next thing which is commonly known to everyone is your Burkitt's lymphoma. Burkitt's lymphoma, c-MYC, most of them know, right? So ignore that AA and everything. This is C, right? So 4 has to be C. That's all. So it's very simple for us to rule out and write the right answer. Fine. Okay. Just give me a second, guys. One second. Sorry, guys. Fine. Okay. Next question. What's the answer? Cell in cell appearance is seen in which of the following types of cell death? This is a different image. There's nothing to do with that. Entosis, very old form of cell death seen in cases of cancer cells where a live cell lives within another cell. That's what is called as an entosis, right? Not used in most of the famous books now. This image, like you guys said, like Rukmini said, is an image of emperipolysis, right? Both in emperipolysis as well as in entosis, a live cell, a living cell will be seen inside another living cell. Okay. See, imagine like an hibernation mode. One cell is struggling, not able to live alone. So it's sitting inside one more cell. Emperipolysis is a very common phenomenon seen in bone marrow and megakaryocytes. Since megakaryocytes is a very, very large cell, one of the largest cell in the bone marrow, imagine it's like a bungalow, has extra space, gets your lymphocytes here inside them. Right? So there's a megakaryocytes here, and these are the cells that are moved inside. How do I differentiate this from your phagocytosis? If I look at an emperipolysis and a phagocytosis with respect to a macrophage and microscopy, almost impossible to differentiate. If it's a megakaryocyte, I will obviously call it an emperipolysis because megakaryocyte does not eat. But it's a macrophage showing an image without any history. It's impossible for anyone to differentiate whether it's an emperipolysis or your phagocytosis, right? Perfect. Next question, a fact-based question. What's your answer? I thought you guys must say it very soon. One of the X-linked dominant disorders which was asked, which might be asked, these is Rett syndrome, right? Rett syndrome is one of the X-linked dominant disorder. What is the classical finding of Rett syndrome? Classical finding of Rett syndrome. Rett syndrome has a beautiful pathogenesis. The finding of Rett syndrome is the finding of Rett syndrome. You have classical repetitive movement, right? So the gene mutated is MECP2, right? That's a gene mutated. You'll have classically repetitive movements in Rett syndrome, right? And also regression of milestones, right? Regression and stereotypic repetitive movements are both a classical for Rett syndrome, right? Okay. One second. Okay. So now, fine. So this MECP2 genes protein is actually involved in the synapses. Imagine there's a loose connection. So if there's a loose connection, touches, goes, touches, goes, touches, goes. So I try to move like this, come back, move like this, come back, move like this, come back. That's a classical symptom of Rett syndrome, right? Anything. Yeah, I just stopped because there is a problem in the reception for some time, right? MECP2 gene is one of the important synaptic protein Because of its absence or alteration, I will not be able to coordinate things. And since MECP2 is very important for synaptic protein, my milestones, what I remembered, I'll tend to forget. Because for developing a memory, you guys know that you need a lot of good synaptic network. The regression of milestones and also your uh, classical movements seen in Rett syndrome. Fine. It's due to the proteins. Fine. Next one. What's the answer? Which of the following age-defining illness? If any cancer has relation to your infection, we'll definitely put it as an age-defining tumor, right? Melanoma is something which is not related to infection at all. So obviously we'll think it's an not as cause of an age-defining illness. Please do remember, if you see few tumors, you have to think of HIV or AIDS, right? I would not put these two under this. I won't see, whenever I see a non-Hodgkin's lymphoma, I'll think of a HIV. Neither for cervical cancer, you won't think of an HIV. Kaposi, always think of an HIV. That's one of the possibilities for me. Or immunodeficiency. There's one more thing. CNS lymphoma. Any question says CNS lymphoma, please think of HIV virus. One more thing. One more type of DLBCL, which is primary effusion lymphoma. Again, think of HIV virus, because these are very characteristic thing which can be seen in case of HIV. Both comes under non-Hodgkin's lymphoma. That's why we put a template of non-Hodgkin's lymphoma for your HIV virus, right? And obviously melanoma is not related to age-defining illness. This is something which is important from general pathology. You have to remember it. Okay, next. Five, six more questions, that's all. HHV8, right, Rukmani? Human Kaposiform virus. Which of the following is primarily responsible for causing graft versus host disease? It's graft versus host, where the graft is destroying the host. For example, if I get a bone marrow, the bone marrow is destroying me, right? The donor is destroying me, right? So the donor's T cells are destroying me, not the host. Host is not the problem in graft versus host disease. See, there are two problems in case of your, let's take this as a graft and host. There are two things in case of an graft, you're grafting, right? Any transplant. If the graft is being, if the host is powerful, we call it rejection. The host, that's the person who receives the organ, is destroying the organ. That is simple rejection. Acute, chronic, hyperacute, everything. If the graft is powerful and killing the host, that is GVHD. Okay, here the host will be destroyed. The person who got the organ will be destroyed. For this to happen, there's one very primary important thing. The graft should be immunocompetent. They should have lymphocytes, right? They have to be immunocompetent, and host should always be immunosuppressed. Only in this combination, graft versus host disease happens. So where all I can have an immunocompetent graft, right? I'm having a graft which is having lots and lots of T cells, lots and lots of B cells. There are possibilities. Most of us will not consider this possibility, but please do remember that though it is rare, it's very common here. Small intestine. Remember Peyer's patches? Full of lymphocytes. Though small intestine grafting is rare, but chance of GVHD there is pretty common, right? And obviously your bone marrow transplant. That's something which all of us will remember. Can rarely also be seen in blood transfusion, right? That's GVHD can be seen rarely in blood transfusion as well. Fine. Okay. I will say to some extent, Nelson, liver transplant, little bit down the road. Spleen, yes, because again, a hematolymphoid organ. Liver to some extent less, because liver does not have that good source of lymphocytes. I want lymphocytes to be there. Liver might have lots of macrophages, not lymphocytes much, right? Maybe a little bit down the road, because it's also an hematolymphoid organ, right? So that's GVHD. And the immunocompetent cells or the donor's T cell is the reason for GVHD. So this donor T cell will go and destroy the host. What cells they will destroy? It will destroy all the fast dividing cells. Fine. So which are the fast dividing cells in your body? Skin, GIT, or in other words, epithelium. Every fast dividing epithelium will be destroyed by the donor's T cell. Donor T cell is always a problem, right? So fast dividing cells, so which means I'll have skin destruction, right? I'll have your GI epithelium destruction, and I'll have not liver destruction, you'll have destruction of the gallbladder epithelium, right? Or your cholangiocytes, right? Because of that, you'll obviously have secondary obstructive jaundice. Fine. Since bone marrow is the common cause, I am ignoring bone marrow, but yes, bone marrow also will be destroyed if it's other things. Fine. You will have problems in your gallbladder or your biliary epithelium. Fine. Because of this, we have classical case of desquamation. You must have read about toxic epidermolysis. Everything will be gone. Diarrhea, yes, better than diarrhea. I will use the term dysentery because it's loss of epithelium in chunk. You'll have blood loss as well as you'll have the fluid loss. Yes, I'll have jaundice. You'll have obstructive jaundice. Less than 100 days, after the transplant, we use the term acute GVHD. More than 100 days, we use the term chronic GVHD. Fine. Okay. It's simple. I'll just ask you a simple question. I want you guys to answer. There are two types of T cells which will act immediately. I don't want anyone's help to act. I'll act immediately on my own. Which is that? CD4 or CD8? And one guy always requires macrophage to act. The second guy always helps, activates macrophage, forms a granuloma, forms a fibrosis. That's a way of activation of one T cell. Which is that? Which will act immediately. Tell that. 8 or 4. You have two options. Simple. CD8 is direct. So acute GVHD you will have CD8 TCA involvement more than CD4. I'm not saying CD4 will never be present, but CD8 involvement is a little bit more in acute because CD8 does not require macrophage. CD4's involvement is a little bit more here in chronic because CD4 always requires an army, interleukin, macrophage, everything to get activated. Fine. Okay. That's a little bit about GVHD. Next one. I hope this question comes in this exam because this quite some time this question has been asked and the the mutation is becoming more and more evident and useful these days. It's a classical symptom of or mutation of Waldenstrom's macroglobulinemia. Okay. Macroglobin means it is a problem with IgM. Macroglobin is IgM. That's why we have your hyperviscosity syndrome. I'm going to compare two things. I have a patient with IgM multiple myeloma and I have a patient with IgM paraproteinemia, that is your Waldenstrom's macroglobulinemia. Both will present with classical hyperviscosity syndrome. Right? Both will present with classical hyperviscosity syndrome. How will you differentiate both clinically? I don't want to say like I will do a bone marrow, I will do a MYD88 mutation. How do you classify clinically? How do you differentiate clinically? Simple, easy. Multiple myeloma is a problem of the bone marrow. Waldenstrom is a lymphoma. Waldenstrom will have lymphadenopathy. Myeloma will never have lymphadenopathy. If you have lymphadenopathy, it is not myeloma because myeloma is a problem of the bone marrow. Waldenstrom is a lymphoma which will have lymphadenopathy. Clinically, Nelson, right? So this will help you to differentiate clinically both of them. Fine. Okay. Next. Pretty big question, but a simple one. '18-year-old patient's hemogram 12 gram hemoglobin, RBC count of 6 million, MCV is reduced, MCH is reduced, RDW is normal, most probable diagnosis. Iron deficiency anemia. Okay, anyone else? Okay, the answer is not iron deficiency anemia. I'll tell you why. Beta thalassemia trait. Okay, the answer is beta thalassemia trait. See, this is kind of a googly, right? So it's very, very important whenever it's microcytic anemia, at least with respect to an MCQ exam, don't always think it's iron deficiency. There are multiple clues here. Iron deficiency anemia will not have 6 million RBCs. Iron deficiency anemia will always have less RBCs because it's a deficiency. Bone marrow cannot produce RBC, right? That's one thing. And like Ram said, RDW. If RDW is narrow or normal, it cannot be IDA. IDA will always have wider RDW, right? So IDA will always have wide RDW, red cell distribution with. IDA will always have a reduced RBC count. Because of the reduced RBC count only, your Menster's index, remember, will be greater than 13. Thalassemia, I am sure you must have read this mnemonic, right? Thalassemia. Menster's index is less than 13 because the denominator RBC count is more in thalassemia, and RDW also will be narrow or normal, less, not wider, right? That's why the answer is beta thalassemia trait, not an iron anemia. We have to confirm with HPLC, but the most probable with this hemogram is beta thalassemia trait, right? Okay, next guy. I just put this markers so that you will not miss it, that's all. It's an old question. I hope it will not be repeated. CA 2729 is one of the things which can pick up recurrence of carcinoma of breast. 15th also can do it. If this question gets repeated, I want you to remember it. That's all, right? I hope it will not be repeated. Some new information. Just remember 2729 can help us to pick up recurrence in the carcinoma of breast. Fine. Okay, sorry. Next one. This is a simple one. This is the last question. We'll wind up in 5 minutes. Rukmini has gone with 3. Why 3? Okay, obese women with type 2 diabetes, hypertension is diagnosed with endometrial type of adenocarcinoma. Which of the following is the most likely genetic defect, right? So when I see an obese women, type 2 diabetes, hypertension, that classifies to metabolic syndrome. The older classification of endometrial cancer, you have 2 types, right? Type 1 you have, and you have type 2 as well. The type 1 is the one which classically presents metabolic syndrome and all those conditions, and type 1 is the one which you will see in the premenopausal or perimenopausal age group, right? Because in type 1, the most common risk is your hyperestrogenism, and in type 1, the commonest mutation is your PTEN. Type 2 was always postmenopausal, atrophic eustress, right? Okay, Rukmini. Fine. And type 2, you will see in patients who are lean. BMI is not an important factor here. There's no hyperestrogenism, and here primarily I think of TP3 mutation. Fine. Okay. So the answer here will be PTEN. That's the right answer here. Type 1 endometrial tumors. Fine. Ram, you are answering pretty decently. If you're stuck at 130, not able to improve, I would say one of the things which you have to improve is concentration. Because you are not answering questions wrongly with much of errors. Maybe you are not able to sit through for 3 hours. If that is the reason, start preparing slow incremental number of questions. Don't do a Q bank module with 10 questions. Do it 40 questions, 50 questions. Slowly increase it, because concentration is something which is important. Or if you feel that okay, I'm not having concentration for 3 hours, I'll never be able to have it. After maybe 50 questions, get up, wash your face, come back. You might ask me, can I do that in real exam? Tell them you want to pee. Ask them to come behind you. If that works, do it. Because you're not making blunders. If you don't make blunders, 130 is something which can be easily improved. Okay, guys. So all the very best. We'll meet you again before the INICET exam. November first week, we have a marathon there for you. We'll be completing entire thing. Just the final things what to look for. Hopefully you guys will complete and ace INICET in flying colors. Thank you guys. Thank you for your patience.